So we're going to talk now about managing seizures, and seizures are usually managed with medications. Typically, the neurologist will begin with a single drug, gradually increase that dose until either the seizures are controlled or the maximum dose of that med is reached, or the side effects are intolerable. And when any of those things happen, they want to get back to a tolerable level and then add a second drug if needed. Many seizure meds have a very narrow therapeutic window, and so blood levels need to be monitored for quite a few of those. Dosages for seizure meds will need to be increased as the child grows. If someone has had seizures and they've been seizure-free for 2 years, they can attempt to discontinue their meds if they're low risk. And those dosages would be decreased gradually because suddenly removing a seizure med can actually precipitate seizures. A lot of anticonvulsants are teratogenic and they need to be changed in pregnancy. So someone with epilepsy or on seizure meds who is thinking of becoming pregnant or becomes pregnant needs to visit their neurologist and have their seizure meds adjusted. The other thing you need to know about pregnancy, though, is that depending on what the risk is, the highest priority is going to be for the seizures to be controlled, because not only do we want to make sure we aren't jeopardizing that patient's life, but seizures are also a danger to the fetus. So there are some classes of seizure meds that are going to be fair game on this test. Okay, these are not all the classes. There are lots and lots and lots of different meds. There are a lot of seizure meds that are very specific to one type of seizure. So these are the ones that are going to be testable. The hydantoins, this is the most common one, is phenytoin, which you probably know by the trade name Dilantin. Inhibits sodium influx, and that stabilizes the cell membranes. They're not addictive. They are not as sedating as a lot of other seizure meds. They do have some sedative properties, and some people really struggle with their Phenytoin because they feel like it slows them down, but they're not as sedating as some of the others. They have a narrow therapeutic range between 10 and 20 micrograms per milliliter. Side effects, mostly CNS depression. They tend to cause people to feel like they have slower thinking, but they can affect the bone marrow. They can cause low platelets and white blood cells. They are teratogenic, so taking them in pregnancy can increase the risk of some birth defects. They cause hyperglycemia with long-term use. So someone that's on phenytoin for years is likely to develop type 2 diabetes. And they cause something called gingival hyperplasia when the gums overgrow, which causes a lot of dental problems. They're also highly protein bound. And remember, when we talk about a protein bound medication, if we have, say we've got 10 molecules of protein, and we have a medication that's highly protein bound, then whatever dose of that medication is administered, 10 molecules worth, so let's say 10 molecules of the medication are going to bind to those 10 protein molecules, and the active medication in the body is going to be what's left over after that. So let's say if we need if we need to have 10 molecules available for use, 20 is given because 10 of those are going to be bound to the 10 protein molecules. So what if we have another med that's also highly protein bound? Then we get in trouble because we end up with more free drug of either one of those drugs or both. What if we have a patient who has a lot less protein than they need? Then we get in trouble and they can become toxic. So remember, it's highly protein bound. The next class to look at is barbiturates, like phenobarbital. They suppress nerve transmission. They cause a lot of sedation. This is one of the earliest anti-seizure meds. The therapeutic range is still fairly narrow. They need levels. Side effects, they're very sedating. There is addictive potential. People develop tolerance, and if it's stopped abruptly, they're likely to have rebound seizures. So The next class of anticonvulsants to talk about are succinamines. There's one called Zaranta, and it's very specific to for absent seizures. Sorry, it's very specifically given for absent seizures. It probably won't work much for a lot of others. It decreases calcium influx. The therapeutic range isn't quite so narrow, but it does need to be monitored. It can also cause blood dyscrasias when it affects the bone marrow, so it can affect production of blood cells. It can affect kidney and liver function, and it is connected with the risk of systemic lupus erythematosus. Benzodiazepines are an old class. You've seen them as anxiety meds, as sedatives. They're also used as seizure meds they're given more often in an acute episode than as a maintenance med, but they can be used at times for some types of seizures. They promote GABA, which suppresses neurologic impulse transmission. They have addictive potential. Patients develop tolerance. They're sedating. And if they're weaned too rapidly off of benzos, they can have seizures again. Imidazolines like carbamazepine, you've probably seen this as Tegretol. They can be used for seizure disorders that don't respond to other meds. They also may be used for bipolar disorder and for trigeminal neuralgia. They have an interaction with grapefruit juice, and someone who's taking these meds and drinking grapefruit juice can develop toxicity. Valproate or valproic acid, you may have seen Depakote or Depakine. They can be used for tonic-clonic, absence, and mixed seizures. Safety of these is not established in children under 2. That doesn't mean they're never given. It means that there's no data on the safety. They also need to be monitored for therapeutic range. They may also be used to treat bipolar disorder, and they can be hepatotoxic. So this is only a few of the classes. These are the only ones that we're actually going to test on this exam. What you need to know is if your patient is on medication for seizures, just like any other medicine, you need to look it up and see how it works. Okay, what's the mechanism of action? And if you notice, all of these have some mechanism of action that slows nerve transmission. That's how they actually decrease seizure activity. So if we slow nerve transmission, we're also slowing down all the nerve transmission. So it can make people feel tired and draggy, or like they can't think as quickly. Some of them actually are sedating and can even cause respiratory depression. So those are the side effects you're looking at. That's one of the reasons we tend to have a lot of trouble with adherence with seizure meds, because the side effects cause people problems in their lives, or they make them feel not like themselves, and so they choose to stop taking them. For seizures that don't respond to maximum doses of multiple medications, there are some other things that have been tried. A ketogenic diet has been effective for some kids. So if a child has seizures that are not responsive to meds and they try ketogenic diet, about half of them actually respond to that. This is a high-fat, low-carbohydrate diet with adequate protein. It induces a state of ketosis. Okay, so there is some risk. It requires vitamin supplements because it's not adequate. There's not adequate of some vitamins, adequate amounts of some nutrients, so it requires some supplements. Some of the side effects: it causes diarrhea, it can cause hypoglycemia, dehydration, acidosis, lethargy, dyslipidemia. It can cause the cholesterol levels to be out of whack. It can cause kidney stones, and it can cause poor growth. So this is not a super healthy diet, but for kids who are having seizures all the time and they're not responding to meds, it can decrease seizures for about half of those kids. Another option for seizures that are not responsive to meds is a vagus nerve stimulator. It's an implanted An implanted stimulator is it generates a signal that delivers an impulse to cranial nerve 10. It's activated with a magnet at the onset of a seizure. So a patient with a vagus nerve stimulator would have a magnet activator. They start having a seizure and someone could stimulate that vagus nerve. 1/3 to 1/2 of patients who have this have a reduction in their seizures. Surgical therapy may be used to remove a lesion that's causing seizures. For seizures that they cannot find a way to treat them, that means they've adequately tried at least 3 medications alone or in combination. They can do a focal resection where they take out or like cauterize or burn, zap the one small focus in the brain. They can actually do a hemispherectomy, or they can do a corpus callosotomy. So they separate the 2 hemispheres of the brain. That decreases seizure activity, but it's going to also have some pretty significant neuro effects. So those are surgeries that are not, they're done less often. Cannabinoids have also been researched for seizures, and there are kids who are given specific cannabinoids for their seizure activity, and it's been very effective for some kids. So I'm looking forward. I'm hoping there's more research in that in the future. Okay, care during a seizure. Patient is having a seizure. Number one, we want to protect them from injury. If we can, we want to try to get them on their side so that if they have any secretions, if they vomit, if they have saliva, that's running out instead of being aspirated. Don't attempt to restrain someone who's having a seizure. Don't attempt to force anything into the mouth. Call for assistance and document the course of the seizure. Administer medications if they're ordered. So if they have a PRN order for meds, we want to have someone bring us those and give them. If they don't have a PRN order, we want to have someone contacting a provider to bring them or to get an order. After the seizure, we want to assess their airway, breathing, and circulation. We allow them to rest and recover, give hygiene care if needed, reassure them, and document. Status epilepticus is when the seizure won't stop or when they have seizure after seizure without recovery time. It can be treated with IV. Usually they start with benzodiazepines like either diazepam or lorazepam. If that doesn't work, they may do phenytoin. If that doesn't work, they may try phenobarbital. This patient may need respiratory support because they can end up having respiratory depression. Of course, someone can't be intubated while they're in an active seizure or effectively ventilated without intubation. So they may, if they can't get it to stop, they may do general anesthesia with midazolam. So general anesthesia doesn't stop the seizure. It may stop seizure activity. So it stops abnormal movements, but they need to monitor the EEG continuously to identify and treat continued seizure activity. The idea is to try to stop the extra movements or the abnormal movements because that's increasing damage. But the seizure is not stopped just because the patient's not moving anymore. They need support with airway, breathing, circulation. Hyperthermia is also common, so they may need cooling if they're having continued seizures. The prognosis for seizures: most kids who have more than one seizure continue to have additional seizures. Children with epilepsy and some other neurologic disorder have increased mortality, but quite a few people who have a seizure disorder and nothing else actually live full lifespan, full lives. Okay, next we're going to talk about cognitive impairment.